have Dr. Chee presenting on trauma. I don't know what aspect of trauma, so we'll request Chee to share her presentation. Yeah, we can see Chee, your slides.
Wonderful.
Very well. Yeah.
Okay, so my name is Yewlin Chee. I'm from the University of Washington, and this is a trauma talk where, for the general ophthalmologist out there, we'll talk about primary closure of open globe injury, what your VR surgeon cares about, why you do a secondary vitrectomy, and then finish with some interesting cases. So the goals of your primary closure is to really help decrease the risk of infection and begin to restore anatomy, and really to prepare the eye for potential subsequent procedures. We know that these eyes often need a secondary surgery. In this series of 848 open globe injuries, over almost 30% needed to undergo vitreoretinal surgery subsequently. So what does your VR surgeon care about? As we all know, the cornea is our window into the posterior segment. And I tell my residents to really consider doing full thickness corneal sutures in zone 1 injuries to minimize posterior wound gape and persistent corneal edema. It is possible to do our secondary surgeries through an eye, even with a very central laceration if it's been closed properly. Because we often put an encircling band on at the time of our secondary vitrectomy, avoid disinserting muscles if at all possible. This is an example of a zone 3 circumferential rupture where we close the wound without needing to disinsert the superior rectus muscle, and to help minimize prolapse of intraocular contents, closed from the front to the back. And then really good documentation of primary closure helps us plan for our surgery. So why do you get secondary surgery afterwards? The indications for vitrectomy include persistent mediopacity and vitreous hemorrhage, progressive vitreous and/or retinal traction and retinal detachment. And the timing is really important. So I think 1 to 2 weeks after your primary closure is the optimal time for your secondary vitrectomy, because this increases the likelihood of a spontaneous PVD and also decreases the chance of significant proliferative vitreoretinopathy. And really, vitrectomy is the method of repair for these secondary cases. So for some interesting cases, this first case is a 17-year-old man with a self-inflicted pellet gun injury to his left eye. His corneal wound was repaired by a local ophthalmologist, and he was sent to the University of Washington. His initial scan showed the pellet inside the eye. And my colleague, Dr. Lisa Olmos-Deku, did his initial vitrectomy, which is shown here. So she placed an anterior chamber maintainer, removed the lens, and found a lot of blood in the back. She found a nasal retinal detachment and a hole in the retina, but she could not find the pellet. And ultimately, she decided to close the eye and leave this for another day. So again, she found a nasal retinal detachment visualized here in this intraoperative view, a full thickness retinal wound, and ended up having increased orbital pressure from infusion through the posterior wound towards the end of the case. We took another image after his surgery and the pellet was still there. And we thought that at month 1, we could sort of see the end of the pellet present behind those corneal sutures in the retina. So I took him back to the operating room, just removed some persistent vitreous traction from anteriorly to where the pellet appeared to be. Because we were concerned of potentially causing hemorrhage when removing the pellet, we went ahead and did laser beforehand while we still had a good view. Some diathermy to some vessels in this area. And then we dissected through tenons and some thin sclera. And with the curved hemostat, remove the pellet. Close the scleral wound with some 8-0 nylon until it was watertight. Fortunately, there wasn't much in the way of hemorrhage. We just did some additional laser and left the patient under air. So at month 1, he was doing well. This vision was most likely because of his corneal wound. So I think lessons learned is to really consider the possibility of an occult perforating injury with a high velocity projectile, and also to consider staging procedures if your visualization is poor. So the second case is one I encountered in training with my surgical mentor, Dean Elliott. This is a 74-year-old man who had a syncopal episode in his bathroom where he hit his left eye. On presentation, he was no light perception. I took him for his primary repair of his open globe injury and found a 17 millimeter zone 3 circumferential rupture. On post-op day 1, he remained no light perception, and his B-scan ultrasound demonstrated a massive nasal choroidal hemorrhage. Subsequently, he became bare light perception, but on post-op day 10, he was no light perception again. On ultrasound, that nasal choroidal had liquefied, and there was also an apparent closed funnel detachment present. So he was taken for secondary vitrectomy. The first thing that was done is draining that choroidal hemorrhage. So you see that dark blood being drained from the choroidal space. Performed a lensectomy. And here you could see a total funnel retinal detachment with posterior incarceration in his scleral wound. All that is bare RPE. It's a little bit of the lens that fell back. All of the retina anterior to the incarceration site was not useful, so it was removed just with the cutter. Subretinal space was readily available, so membranes were peeled. And then a 360-degree retinectomy was performed to cut the retina out of that posterior wound. Perfluorocarbon liquid was used to flatten the retina. And laser was applied. And pretty miraculously, at month 4, he was 20/50. So I think lessons learned with this case is that secondary vitrectomy can be considered in an NLPI in the presence of a massive choroidal hemorrhage. Typically, I don't offer surgery in NLPIs, but this is the one instance where they might experience some improvement. Now, this final case is a 34-year-old man with a nail gun injury. You can see a small entry wound at the base of his cheek. And on indirect ophthalmoscopy with a 20 diopter lens, this is what we saw. So there was a through and through injury with the nail, attached retina on one side and vitreous hemorrhage on the other. Imaging confirmed the through and through injury and also demonstrated that the end of the nail was in the frontal lobe. So the operative plan here was to transfer him to the operating room in conjunction with our neurosurgery colleagues, locate the nail and remove it, and then do an intraoperative CT scan. That was a nail after it was removed. Fortunately, he had no cerebral hemorrhage on CT scan, and I went ahead and closed the globe. At week 1, he had an inferior retinal detachment, not really well visualized here, but his entry wound was present in the anterior inferior periphery, and his exit wound was present supranasal to the optic nerve. I took him back to surgery, placed a scleral buckle, removed his lens. And in these instances, it's very important to make sure the hyaloid's elevated around the entry and exit wounds. So here we are lifting the vitreous and separating it away from the exit site. Just preparing the retinectomies around each of the wounds. For my posterior wounds, I'd like to use vertical scissors just to preserve more real estate. And it's very important to make sure that the retinectomy is complete. So here we are just lifting the retina away. And for the more peripheral wounds, I think using the vitreous cutter is perfectly reasonable. We're flattening the retina, applying some laser. Ultimately, I left him under oil. We trimmed the buckle and closed the conjunctiva. So at month 9, he was doing well. He was 20/40 with an aphakic contact lens and his oils out. So I think this case demonstrates the need to always evaluate for other potential injuries in the setting of ocular trauma and coordinate your care with other services. And Mark had mentioned earlier how location of injuries or locational lesions are so important. But even having a very large nail through one's eye, you can still do well if your injury is away from the vital structures of the eye. Thank you. Be happy to take any questions.